this is a topic, really just try to set the stage for the day. We talked a little bit about this yesterday in terms of natural history, of Chiari. This is a really important issue. Any disease that we think about, we always want to know what's the 1 year, 5 year, 10-year outcomes. We had a lot of questions last year in San Diego from patients about, does Chiari affect how long I'm going to live? These are deep questions that we haven't ever thought about really, because we're in the moment. We don't have any evidence of that issue, but it's still, these are scary topics to think about. What happens 30 years from now? Unfortunately, we don't know a whole lot, right? We don't do what we call these natural history studies, which are potentially without treatment. So we don't do surgery. What happens over years, of having a diagnosis of a Chiari? Are all Chiaris the same? Well, we made that pitch, that they're quite different. Pediatric and adult are different. The comorbidities clearly set these diseases apart, and we still try to understand. There's a whole new definition of Chiari coming. I don't know if you know about this, but it's still in the underground right now. But there's a few of us talking about a definition that's no longer sort of based on just tonsil descent 5 millimeters, which is clearly very, tip of the iceberg of this disease. We need to do better. That was defined, as talked about earlier, the first day, a long time ago by Hans Chiari, and pre-MRI, okay? We can do so much better than that. So it's a whole different classification. It's hypothetical. We're starting to get into this new area of calling it, different names. And so this is coming. But I hope it'll help us classify better and help us get to a natural history that's more meaningful as opposed to Chiari. Because Chiari, it's a big deal how this was picked up, right? Was this a concussion that led to an MRI that showed a Chiari? Were these headaches for months that led to a scan? Was it a seizure? What was it, hand issues from a Syrinx? What led to the scan is always incredibly important to think about, okay? But this is all about natural history. Luckily, they gave me 3 hours for my talk, so I can ramble for a while here. This is clearly what we're studying, right? We know this definition. But we talked, Dr. John Heiss talked about this yesterday, the disproportion, right? Tonsils too big, small posterior fossa. It's not just here, because look what we talked about yesterday that Dr. Dowie presented from Iowa. Look what's going on in the front, the odontoid, the ligament. He talked a lot about ligaments back, yesterday. And what does that mean? This whole area of development is all happening together. So we don't just focus anymore on just that. It's the entire region. How high is the odontoid? Is there basilar invagination? What is there instability, laxity of the ligaments and the Chiari in the back? Is this a Chiari 1, Chiari 1.5? These are all important to think about up front. In my mind, that's how I classify patients in terms of how often we need to follow them. What is the risk for a Syrinx if they don't have one? That's a common question. Will I get a Syrinx? How often do I need to look? Well, we've seen those pop up pretty quickly sometimes. And could we have predicted that? That's where we're in now with the AI that will be presented later. We need more machine learning, we call it, which are ways to look at these images over decades, not months, years to come. And we get that as a pediatric neurosurgeon because we luckily get to follow patients as they get into young adulthood. But in the adult side, it's rare. You may have never gotten an MRI, and now you're 32 and got to have a Chiari. Well, is that new? Is it acquired? Was that there 2 years ago? There may have been a low-speed car accident, which is when the neck pain started, which led to the scan, but you had no neck pain before. Shows a Chiari. Was the Chiari there before? This is what we wrestle with, all the time in the clinic. And we have to say what we know and clearly state what we don't know and be very honest with that, okay? Because this comes up a lot. We're not going to belabor this anymore in terms of what this means. I think we've talked about this a lot. Can a Chiari get better on its own? Now, many would come and say, well, this is a tight Chiari, tonsils are down 20 millimeters, that's a lot. Minimal symptoms, but they're like, well, if we need to do this, let's get it done. Let's do it now. Get it over with. I'm only getting older, more comorbidities, hypertension, other things that make surgery riskier. Why wait? Get it done. So that assumes that this is a progressive condition that will only get worse, right? Which is not the case. We have more and more evidence that many of these we just watch, and if we didn't know about it, probably would have been better, right? Because it's not causing any symptoms. It's just causing, a lot of psychological stress of, I have a Chiari, what should I do? What should I not do? Does that cause more risk? In the kids, it's always, can I be on a trampoline? Everyone seems to have one now in their backyard. It's the worst thing a neurosurgeon would ever want to talk about, but bouncy houses, roller coasters, lacrosse. There's a whole lacrosse teams you see in the hotel. Some of those kids have Chiari, they don't know it, right? What if we pick it up? Should we let them play? Does it matter if they have a Syrinx? In the Air Force, how many ex-military folks or military folks in the room? There's a lot here, actually. I've talked to many of you. It's amazing, and thank you for your service. In the Air Force, there was a pilot. They hate getting MRIs, right? Because it shows stuff. Just like an NFL player, when I was taking care of the Niners in California, same issue. They do not want to be scanned because you find things and then you have to ask the question, is it safe? So this pilot, I remember, had a very tight Chiari malformation. But he came in with just a little shoulder pain or something from something unrelated to a military. And of course, I had to sign all this paperwork that it's safe for him to eject out of an F-16 with a Chiari. Now, do I have any data about that? No, we have no idea. And the DOD is really worried about their plane, right? So these are tough discussions. And again, what do we know? What do we not know? And asymptomatic Chiari have been flying for 30 years. Am I going to pull them off and say you're not flying anymore? I mean, that's a big move. No different than professional athlete that you pick these things up. Is there a risk with a severe flexion extension? All this is part of natural history, though. It's all very important because you don't know about people's lifestyle and kind of what they do. So it's not so easy. But yes, clearly Chiari, one, can get better with time. So much evidence for that. We studied this at Duke years back with some of the volumetric relationships that were showed about the volume. At a very young age, that mismatch in volume can self-correct. The brain growth slows down, the bone grows faster, and the Chiari can reverse. That usually happens, though, in kids that have no symptoms. That was picked up for, again, other reasons those Chiaris can reverse. Different than the kid that has a lot of symptoms. I don't see those going away a whole lot. So these are, again, we need to do better in terms of classification of these different things. But clearly this is documented, okay? One scan and the other. Complete resolution of the Chiari. We haven't done anything, just time. And actually not that much time. I'm talking a couple years. Again, we can watch things if they're asymptomatic, right? Pretty tight Chiari here. This is more bordering on what we call 1.5 malformation. I talked about that the first day. And this is in follow-up. Again, these are more kids than adult. We have seen the same in adults, less common, but it does happen. Why is that? We have no idea. Maybe it's related to a leak issue that Dr. Gray talked about that's self-corrected. I mean, that's possible, right? Otherwise, it's hard to think about why that would happen because the brain's unfortunately not continuing to grow after, 19, 18. I mean, it's all downhill, unfortunately. So here's an 8-year-old boy, headaches, back of his head, pretty classic, arm paresthesias, normal exam, no eye swelling, so it's a kid that worried about. I would call this kid symptomatic, right? If he had a Chiari, there's something going on. This led to the MRI, pretty tight, right? Chiari malformation in the back. Ventricles are up a little bit. You can see. Has a little streak. Now, remember Dr. Fuchs's lecture? Is this a dilated central canal? Is this a Syrinx? You're all experts now. How many think central canal? How many think Syrinx? Yeah. We have no idea. I wish I did, but this is hard. It's going down the whole spinal cord. Looks pretty benign looking to me. It's not bubbly like Dr. Fuchs talked about. Remember swallowing the snake, swallowing something? If you remember that analogy? I can't get that out of my mind. I hate snakes, by the way. Here's repeat 1 year. Whatever that was, it's gone in a year. 1 year, gone. And a lot more room up there. What happened in a year? We have no idea. Now, I've seen this in kids post-viral. We talked about this. Where is she? She was up here. Is she? Okay. You have your hat on, don't worry. So, post-viral, this kid did have a viral infection. It's very interesting. And had a terrible amount of coughing for about 3 or 4 weeks. A terrible viral bronchitis. That was the only thing close to the diagnosis. Was the straining, the coughing somehow led to the Chiari, which now completely resolved a year later. We didn't operate on this kid because the exam was normal. Family was like, well, we just did the scan. And I was like, okay, let's pull back and just kind of watch very, very closely. And this thing was just reversing on its own. So these are cases that aren't the majority, but they're enough that we think about these. It's always on our mind, right? A lot of papers have tried to look at this. These are not hundreds of patients. And of course, some have surgery, some don't. Already that's biased, right? Because there's this population that presented to a neurosurgeon. They decided some reason not to operate. We don't know why not. Some got operated on, they're already out. But what was different about them? Obviously, the best study is you just watch everybody and don't do anything and see what happens. But we don't think that's ethical, right? Because some people are having a lot of symptoms and they're sick and we need to treat them and they get better. That's important. So natural history, this is in adults. Look at the great conclusion. Due to the heterogeneity of articles, no consensus about indications of surgery in asymptomatic patients, meaning just to have no idea. It's all over the place. And these adult studies. Adults are the hardest because the phenotypes are so different, so many more different comorbidities. We don't know how to plug those in, and none of those were accounted for here. Natural history following conservative management, but this is Cormac's paper. I think Cormac awake yet? No. I think he actually had to go back to Stanford. But natural history. But there was already a decision made not to do something, right, which is biased. So we have to keep that in mind. That is this truly a natural history study? No. But it's a bunch of kids that had Chiari that were watched, clearly, okay? Did the tonsils change after the Chiari was diagnosed here? All over the place, but not really going up and down, right? Tonsils pretty much the same, okay? This is after the Chiari was diagnosed. The mean tonsillar herniation, this is insignificant, really, okay? So that didn't change over years post presentation. Now, almost 150 patients that were watched, there is a change, actually, but the average is the same, okay? Some herniate more, some less. But this is a pretty mixed bag. This is the typical, we call the bell curve. You have some outliers. Who knows what's going on there? You get a minus 14 versus a plus 20. I mean, it's wild to me. How can that happen? But it clearly happens, but it's rare. But this is the majority. There's some change, but maybe it doesn't matter because they must have been pretty asymptomatic if we've watched them, right? What if the tonsils are lower? Does that make it more likely to have a syrinx? That's a common question we get. Do we have to scan more frequently because of something we see on that scan that we think is a setup for a syrinx? We're not very good at that. That's natural history data, okay? This is the data here in that paper. Number of patients, quite a few number here. Blue is the patients without a syrinx. Red are those with a syrinx. Is there any relationship there? I wish Cormac was here because this is his paper, but you could say there's definitely a little bit more red as the tonsils go down, maybe less blue. So it seems to be there's some relationship. Lower the tonsils, clearly it's more of a severe Chiari. Maybe they're down 15 millimeters or something. That's somewhere here. But you're still seeing some blue there. So I would not say this is very clear. The statisticians would have a field day with this. They would not like me saying that tonsil position is a risk factor. I don't believe that's the case, that we really know that's true yet. That's a bold statement, because then we would say tonsils greater than 10, much more likely to have a syrinx, start scanning every 3 months. Scans are not trivial, as you know. There's cost. Some can't stand MRIs, the claustrophobia. Kids, you have to sedate them maybe. This is a lot, okay, to think about this surveillance. And if anything, with, say, brain tumors, we pulled back. We don't scan as much as we ever used to. We've backed off based on genetics, a little bit more understanding of the tumor. Chiari, we don't have that yet, okay? So we're still always worried, like how often do we scan? So clearly some got better, some got worse, as we talked about, but very hard to classify. These are the ones that got worse. This kind of went to that. Syrinx started forming, so there are some that do worsen. So although I've painted this picture that some improve, some also get worse. And we're not so good at predicting that, but these are pretty tight Chiaris that have gotten worse. This is about over 4 to 5 years in time. But sure, you can have a syrinx form. Personally, I see what Dr. Iskandar and others do here when they talk, but kids I follow a lot more rigorously because there's a lot of changes going on. This is why scoliosis changes, the adolescent. So until the growth stops, I am following them pretty carefully over time. Even after I did surgery, I don't let them out because there's changes that can happen over time. Adults, I would think less so, actually. Those relationships, the proportions are not changing as much. But what are the risk factors for developing a syrinx? Well, maybe this, okay? Still debated. If they're peg-like, so it's tight and those tonsils are jammed in there to a point, right? I don't mean a nice fluffy soft tonsil, but jammed in. And this is where the definition doesn't help us, right? It just talks about how far that tonsil goes down. We don't think like that. I want to know, is there room there? Is it crowded? All these other things. The cine flow we talked about. I know there was debate, but this is the tough part about this. Decreased flow. I'm sorry, I went back. Interestingly, gender comes up. Girls are more likely to develop a syrinx. It's very interesting. They're also more likely to report symptoms. This has been studied in concussion a lot. Why do girls have more concussions than boys? There's a big debate about all this. Is it hormone-related, ligament laxity, by age? There's a lot of factors we don't really quite understand. But there definitely is in the concussion world, we know in sports, there's a delay in the maturity of the ligaments in a young girl versus a boy at that same age. It takes longer for those ligaments to mature. You know that from all the knee injuries they're getting in soccer. Some of you know those, the ACL risks. There are sensors been put on the kids and looking at all this. There's data behind that about age and gender different. So I think that's what's playing into Chiari. Look at all the ligament issues, the hypermobility that's much more common at a young girl's age versus boy. So this is all kind of makes sense. Personally, I feel, well, the 1.5s I'm watching much more. That's where, again, not just the tonsil, but the brainstem sags with it. Right? This is a bigger entity that I worry about more. Family history, I personally feel, hasn't been proven. I don't think Allison's anymore, but that genetics do play a role here. If I have a family members of Chiari, I follow them more rigorously. I think they get into more trouble. That's my personal reflection, not based on any proof, but I do watch them. As Bree knows, we're watching those kids much more. That's 2 or 3 kids in the family. Mom and dad has Chiari. You know, there's a lot more to this, and I don't understand it, but they get more symptoms that I think over time. Tethered cord is a big one, right? We haven't talked a lot about that yet. We will. You know, the spinal cord, if it looks normal, is there an occult tethered cord? You know, does the fat have phylum in it? What if the conus is a little bit low, the bottom of the spinal cord, down to L3? What does that mean for Chiari? But if there's something down there, I'm also a little more worried. If there's more fat or something like that we might pick up. I always get a full spine MRI, you know, before I operate on someone. That's me. I don't want to miss anything going down that spine that could contribute to the Chiari. I want to know about leaks. Dr. Gray's brainwashed me. I need to look for that every patient. I need to look for a tethered cord every patient. In the adult world, that does not happen very often, that people are scanning the whole spine. It's just rare. C-spine or brain, Chiari, operate if there's symptoms, right? But there might be some things going on. They were kids at one point, and there's some congenital things that we would rule out. And if they've never had a scan of the spine, I think it's important to do that once. It doesn't change. The spinal cord's not going to change later in terms of where that spinal cord ends. That's a common question as well. Maybe I have a tethered cord now, maybe it's lower. We don't see that change. We see it early in life, but not as an adult. This is more the 1.5. It's crowded. Look at the brainstem. This buckling here, you see that bubble? That's the brainstem. I mean, there's a lot more going on here than Chiari 1. Very tight back here. The tonsil is actually here, and this is all brainstem and spinal cord. Much tighter appearance. This one had a syrinx, but I do feel this is something that is important to keep an eye on. So there are other studies, you know, looking at natural history, non-operative outcomes, many symptoms from our conservatively managed cohort improved or stayed unchanged. Again, this is still biased. Maybe the Chiari was more mild, you know, it just barely met the definition, but it's 5 millimeters. Still could have lots of room around the tonsils, not peg-like, but they're getting better. So cough, headaches, negative predictor of symptom improvement. So if they had cough, headaches, the Valsalva headaches, those are much more classic problems from Chiari. They don't do as well. So that's something we can take home, okay? That's a real symptom that, you know, we always ask about. Valsalva headaches, cough headaches, that sort of thing. So that, I'm not saying they should be operated on, but that's a patient you're going to be following much more frequently. Okay, looking at these survival curves. This is not survival of life. This is survival without neurosurgeons getting in the way. All right, these are non-operative survival. So these are the patients that did well, that never required surgery. You see 226 people, pretty good. We're in the 80s, okay? No surgery on these people, followed, well, 60 months. It's a pretty good amount of time, you know, 5 years, okay? So I thought that was a really interesting graph to see that. We always look at this in cancer, but this is a really good survival, thinking about, well, if we don't do anything, what is the long-term risk? Again, these are people, minimal symptoms, no Syrinx, et cetera, okay? There's no question my practice and how I think has changed over time. We have to change. We have to keep evolving. Dr. Bolognese talked about that, right? Look at how he changed his technical side over the years. I've gotten more conservative watching these Syrinxes. Who has taught me that? Our Chiari 2 patients. The Chiari 2 spina bifida kids have these Syrinxes that seem to oscillate and come and go. And in spina bifida clinic, I always wondered about that. And then you start seeing that in Chiari 1, and that kind of helped me back off a bit to say, maybe we should just watch a little longer. Again, that's the child that doesn't really have a lot of symptoms we're wrestling with, but I'm not just going to operate Chiari Syrinx surgery. That algorithm is not something that's not that simple. Okay, I think it has to be very personalized. I wish we had something else, biomarkers, mast cell, genetics. We need more, okay? But that's all we got. Another article about natural history in the pediatric population. Majority, 92.9% managed conservatively, do not have progression clinically or by imaging. That's pretty powerful. Another paper from Europe looking at spontaneous resolution is rare, but not unlikely. 25 cases. It's used to be case reports. Now there's series about these, so it's not a new finding. More common in the kids as the skull's growing, like we talked about. Okay. Again, adolescence and adulthood, we don't know how much that happens. Same thing I was saying. So this kind of reviewed that on these larger series. What about a Syrinx? I talked about Chiari 2 and that sort of thing. Idiopathic, most common, no Chiari. But what happens to a Syrinx over time? We pick these up a lot. It's one of the most common things we see in clinic. They may be presented with back pain, something. No tethered cord, no Chiari, Syrinx. Do we operate on it? Well, that's a pretty big surgery, actually. To operate on a Syrinx is putting in, if there's no other cause, we're putting in a syringo-subarachnoid shunt. That's a tube we're putting into the spinal cord. You're going through normal spinal cord to put a piece of tubing in. Yes, it's a small tube, but you are going through spinal cord. Chiari surgery is not like that. We're not going through brain to get to something. We part things, but we're not going in through tissue to get to some other place like we do, say, for a tumor or something. It's a very different kind of way to think about risk-benefit. Natural history, this is probably the best paper. Pretty weak, though. 17 patients, that's nothing for natural history. And this is a really weak area that we don't know much about. So I was pretty sad when I really looked into the Syringomyelia, natural history, and a couple people got worse. Who were they? Well, they had Chiaris. So this is the reverse world in Syringomyelia that, yeah, there's sometimes secondary to something else. This is not idiopathic. It's all Syringomyelia. A couple developed Chiaris, or the Chiaris led to a bigger Syrinx over time. So that, I wasn't too impressed with what happened there. So at the end, these last two slides, remember I talked about ChatGPT. Everyone know what that means? I brought this up the other day, but I'm not sure you live in this world. You know, this is a very common world in the elementary schools now, in the high schools. Kids will now go to ChatGPT for their answers. It's unbelievable, right? I don't know how the teachers are going to manage this. They're trying. But I asked the same question. I said, well, give me the answer. I promise you I did this after I wrote this talk, not before. But I said, let's give it to me. Here we go, okay? I asked the question, what is the natural history of Chiari 1 malformation? Here we go. Ready? Condition where the brain extends into the spinal canal. Got that. I hope we all know that. Skull is small. We talked about that. Or misshapen, right? It's doing pretty well. Pressing on the brain or forcing it downward. I'm not sure we know that. Forcing, we don't know much about that. Dr. Williams taught a lot about this. I loved his work. You know, this is really interesting, thinking about push, pull, suck theories, all those sort of things. So I don't really know if that's true, but this is what ChatGPT gathered from the evidence in Google or anywhere it could find evidence, right? Natural history can vary. For many patients, those who are asymptomatic or minimally symptomatic, the natural history is generally benign. I would say that's kind of what we've been reviewing this morning, right? Some with Chiari 1 are managed without surgery and do not experience progression. Pretty good. In fact, some even see spontaneous improvement. I was excited to see that there. I didn't bias this. This is just let it go, see what happens. But there are cases where progression occurs, neurologic deficits develop, Syrinx could follow a varied, unpredictable course, totally agree, with Chiari 1. Some indicate that if patients with Chiari 1 are going to get progression, it's going to happen in the first 2 years. Well, that's interesting. I didn't talk about that, but there's a paper on that I showed. It was the Greg Albert paper. Not much evidence of that, but yes, in their series, it happened earlier after diagnosis, first couple years of diagnosis. But again, age, what are the symptoms, what led to the scan? I'm not sure I would hang a lot on that, but again, this is post-diagnosis. This is not after you develop Chiari 1. We have no idea when that happened. Post-diagnosis, maybe in the first couple years, it's higher risk. That's something to keep in mind. Are you impressed with ChatGPT? Not bad. Yeah. Well, now let's do the same for Syringomyelia. A little bit more, even though there's less evidence, we got more stuff. So I asked the same question. Okay, you have Syringomyelia associated with Chiari. Symptoms usually begin between ages 25 and 40 with congenital Syringomyelia. Well, why is that? That means it's already saying the Syrinx was there when they were a baby. How do we know that? We don't. These are very commonly picked up as a child. We see them all the time. So this is where ChatGPT kind of doesn't give you the full story, right? Often linked to Chiari, okay, but most commonly it's not. Most common Syrinx is idiopathic, way above everything else we see. No tethered cord, no Chiari, nothing else to go by. Arachnoid cyst, whatever it might be. We talked about a lot of these etiologies. Symptoms can develop slowly, may worsen over years. That's someone that we already know has Syringomyelia. I would say it's probably not that kid I showed with that central canal Syrinx. I'm not sure. Those aren't the kids we're really worried about, right? These are talking about the bigger Syrinxes, the ones that we showed, yesterday. Those are first day. We've been here a while. Wow, Tuesday. So those are much bigger Syrinxes. Progressive symptoms, weakness, stiffness, headaches, sensitivity to pain. These are all real issues that we worry about. In children, scoliosis may be the only symptom. Interestingly, that's new. Dr. Menezes taught us this. That scoliosis is a symptom. It's beyond a sign. It's a symptom of potentially Chiari and/or Syringomyelia. And that's all Dr. Menezes' work. He is very worried about a Chiari itself causing a scoliosis without a Syrinx. It's a very interesting story based on his data. Progression, unpredictable, some worsen. In the pre-MRI era, okay, we're going back to the 70s now. Syringomyelia presented late as a crippling neurologic disorder. Think how we picked up, Dr. Gray, how do we pick up Syrinxes in the 70s? I mean, would a myelogram show it?
Yeah, a myelogram would show an enlarged spinal cord and, a small subarachnoid space, and that would be it.
That would be it.
Yeah, that's it.
But there's nothing else that can really show.
No. And sometimes, if the late image will show leaking of contrast into the central canal. Or into the surface.
So, pre-MRI, but we sure see these patients, right, with Syrinxes that were large for years. I do worry about those big Syrinxes over years. And these are tough because the patient may not have a lot of symptoms, and we're looking at the picture, which looks pretty ugly, and you just keep watching it, and you're just very nervous about that big Syrinx, because I'm not thinking about next year. I'm worried about 30 years from now. What is this kid going to look like? And we don't know the answer. It really bothers me, because I'd love to be more aggressive with that. But everything I do has risk with that Syrinx. So these are tough situations. These are particularly in kids with some of the connective tissue disorders, a lot of head hypermobility, where Noonan syndrome, for example. I follow many kids with Noonan syndrome, which have a lot of laxity in their ligaments. If we operate on a Chiari in these young kids with ligament laxity, I can make them worse, because now we've decompressed back here. We went through all those muscles, Kid has quite a bit of neck discomfort for several months, needs extensive physical therapy to get that neck stronger. Did I do that kid a service? And a young 6-year-old say with Noonan's, we have to question that. Poor correlation, we talked about this day one, between the size of the syrinx and symptoms. Some can have large cavities and have minimal symptoms. That's the mismatch that we don't understand. Why is that? I mean, some looks huge, and how could they look so good? It's amazing. Clearly that's been there over years, right? If that came up overnight, you'd be very symptomatic from that syrinx. So these are long-standing, but don't think that that MRI is picking this up and it's all new. It could have been there 10 years if the kid's 12 or so. We really don't know. Don't assume anything is the way I think about these. I appreciate your attention. I know we went through a lot to think about natural history over time, but that timepiece is what is so important. And that's where ASAP and others, the research we need to get to. We need to develop these registries. We need to get much more rigorous. They're very hard to do this. Dr. Iskandar did a credible study years back looking at, say, tethered cord and all. These are hard to do, these multi-center studies. They're very expensive to do them right because we need to know a lot of information, right? To look at patient A versus patient B, they're very different. And we need to know everything about them so we can eventually say, okay, their genetic biomarkers are different, their CSF markers. It's not just the MRI, right? We need to know a lot more background. So who's going to get all that information put into some database? That's a lot of research coordinator effort and time. That's why the research is so expensive to do it right. It's always this garbage in, garbage out, if you've heard that. There's a lot of that in Chiari. It's always back to the original diagnosis. How is the MRI picked up? Did the patient have symptoms? What are the symptoms? Do they have sleep apnea? Do they have a syrinx? Do they have hypermobility? Do they have dysautonomia, POTS? We don't ask all those questions. And these, they're very simplified. They're often patient surveys that you might do online. That doesn't mean anything to me. It's very hard to study that kind of work. So we have to do it prospectively, right, over time, not retrospectively looking back over the last 100 patients, which are most all the natural history studies. So I appreciate your attention. Thank you.